everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Welcome back, everyone. Today we're going to have a good look at a paper recently published in Diseases of the Colon and Rectum, entitled A Mutation-Specific Decision Model for Segmental versus Total Abdominal Colectomy in Hereditary Nonpolyposis Colon Cancer. Following that, we'll be having a quick chat about the normal distribution and particularly some characteristics of distributions that can be relevant. We're looking at your data such as skewness and kurtosis. I'll leave you to it.
Right. So hello, everyone. My name is Pratik. I'm one of the registrars working in Huddersfield Hospital in upper GI surgery at the moment. And I'm with Max. He's one of the SHOs working in Sunderland. And today we are going to be presenting a paper which is titled A Mutation-Specific Decision Model for Segmental versus Total Abdominal Colectomy in Hereditary Nonpolyposis Colorectal Cancer. This is by Leung et al. And has been published in Diseases of Colon and Rectum this year. I think it comes out of Mayo Clinic in America. So if you, next slide, please, Max.
Yep.
Okay, so to introduce the paper, HNPCC is an inherited autosomal dominant condition accounting for around 3% of newly diagnosed colorectal cancers. 5 MMR genes, namely MLH1, MSH2, MSH6, PMS2, and EpCAM, are predominantly implicated in HNPCC, with different lifetime cancer occurrence and metachronous spread rates between them. This study aimed to compare segmental colectomy versus total colectomy in newly diagnosed HNPCC patients with colon cancer via a mutation-specific Markov decision model. So essentially, they wanted to see with patients with newly diagnosed colon cancer having Lynch syndrome, with these mutation variants, which surgery had kind of better outcomes. They wanted to compare their outcomes. So next slide, please. So looking at the UK context for Lynch syndrome, with regards to surgery, for Lynch syndrome patients with MLH1 or MSH2 mutations who develop colon cancer or colonic neoplasia not amenable to endoscopic control, the decision to perform segmental versus total or near total colectomy should balance the risks of metachronous cancer, the functional consequences of the surgery, the patient's age, and the patient's wishes. For MSH6 or PMS2 mutations, there is insufficient evidence for oncological benefit of extended colectomy over segmental resection. This is as per the ACPG-BI guidelines. Next slide, please. So in this paper, the authors have conducted a digital experiment. They have simulated cohorts created based on data from literature review. They have compared two interventions, segmental colectomy versus total abdominal colectomy, in 3 different mutation variants at the first diagnosis of colorectal cancer. The outcomes of interest for the authors were mean survival and mean quality adjusted life years. The cohorts were run through a state transition model, also called as a Markov model, in TreeEdge Pro software. Next slide, please. So the authors simulated cohorts of 100,000 patients, each with same age at diagnosis and MMR mutation. The varying cancer stages at initial presentation was according to what they found in literature, which we'll talk about in one of the next slides. So this led to 3 different cohorts for MLH1, MSH2, and MSH6. Now each cohort underwent one of 2 initial surgical strategies, either segmental colectomy or total abdominal colectomy. So you've got like 6 groups already. So each of these groups were subjected to an annual cycle in this model. And in this annual cycle, patients were subject to risks of having metachronous occurrence and mortality. The models were run until the patients reached the age of 100. And the models were run at varying ages of diagnosis. So starting from the age of 25 to the age of 70 years. So 10 different kind of start ages. So if you take an example for MLH1 gene with a newly diagnosed colorectal cancer, there are 100,000 patients of various cancer stages at initial presentation. This one set of 100,000 patients for this MLH1 gene had segmental colectomy. Another set of 100,000 patients had total abdominal colectomy. And these 2 groups of patients had kind of a simulated life cycle up to 100 years of age, where they would have either metachronous occurrence or mortality, and the outcomes of interest were calculated from that. And this was done for each initial age. So, for example, patients presenting at 25 years of age with MLH1, first cancer diagnosis, and had either segmental or total abdominal colectomy. So, next slide, please. So this is the mix of population in each cohort according to stage distribution. So stage 1, 2, and 3 of the colorectal cancer in each cohort of these 100,000 patients. So about 30% stage 1 cancers, 45% stage 2, and 25% stage 3 cancers. The table also shows what metachronous occurrence stage was considered in this study. They also assumed additional mortality associated with HNPCC as 0% in this study. And there is also mentioned in this table of the postoperative utility rates, which we'll get into in one of the next slides, DC utility and global discount rate, which we'll talk about in the next slide. Next slide, please. Okay, so talking about mortality, how did they calculate that? Annual risk of mortality. So each year of the cycle, risk of mortality was calculated as cancer-specific mortality. The data was found from SEER data, and actuarial mortality. That is the mortality which occurs in the general population. 10 years after the diagnosis, the patient's cancer-specific mortality was assumed to be 0. The actuarial mortality was assumed to be 100% at 100 years of age. Additional mortality associated with HNPCC was assumed to be 0, as with the previous slide. And procedure-specific mortality was from the NSQIP database. However, there was insufficient data for ileal pouch anal anastomosis surgery, and the mortality was assumed to be equivalent to total abdominal colectomy. Next slide, please. So talking about the risk of metachronous occurrence, they use the prospective Lynch syndrome database to calculate the mutation-specific risk of metachronous occurrence from the ages of 25 to 70. After 70 years of age, there is no data in this database, so they extrapolated using the forecast function in Excel from ages 71 to 100. This is kind of a linear kind of extrapolation of the available data. They assumed that 50% of risk of, because they didn't have data on separate colonic and rectal metachronicity, they assumed 50% risk of colon and 50% risk of rectal metachronous cancer. Therefore, the risk of metachronal cancers after each initial segmental colectomy was assumed to be twice as that of initial total abdominal colectomy, as per the paper. Next slide, please. Talking about the quality of life aspect, they gave utility states of 0 to 1, 0 being the minimum, 1 being the maximum. And each year you will get to accrue the utility, and the utilities would accrue into the quality adjusted life years. If a patient had total abdominal colectomy, their utility was put at 0.95. For segmental colectomy, it was 0.99, and ileal pouch anal anastomosis was 0.89. If a patient had an operation in a certain year, 0.15 quali was subtracted in that year for the patient. And what they did also was to apply a 2% global discount rate for qualis throughout the whole population. Everyone had 2%. So what that means is the quality adjusted life years tend to decrease each subsequent year because of this 2% discount rate, which essentially assumes that the value given to quality of life presently in the present day is more than that in the future. So they have applied this 2% global discount rate. So if we look at the two different operative options, patients undergoing segmental colectomy ends up in a post segmental colectomy status, and then every year the cycle runs. Either they are alive, or they die, or they have a metachronous cancer, either in the colon when they will have a total abdominal colectomy, or in the rectum when they will have IPAA, and then again post cancer status, so post resection status, they can be alive every year or die, depending on the statistics that the authors have used for so rates of mortality and metachronicity. Same for the patients who started with total abdominal colectomy. Each year they could be alive or have metachronicity, and then subsequent operation, and then eventually death. And the rates were calculated. Okay, so I think the next is results, and Max will discuss them.
Thanks, Pratik. So moving on to the results, if we look at the outcomes that they were trying to assess in terms of survival, when you look at the diagnosis at age 25, overall, a total colectomy offered a less than 1 year increased mean survival difference compared with segmental colectomy, irrespective of the mutation that was present in this diagnosis. This difference decreased overall with increasing age of diagnosis. Okay, so there was less of an increase in survival as you increase the age of diagnosis. When we look at quality adjusted life years, again, we see similar figures. So segmental colectomy offered a less than 1 year benefit compared to total colectomy at a diagnosis age 25. One thing of note is that the MSH6 mutation patients showed a decreasing quality of life benefit as the age of diagnosis increased, which might be related to the lesser metachronous occurrence rate that occurs in this mutation. The others remained pretty stable. In terms of subgroup analysis, we didn't really touch on this in the methods, but essentially they varied the utility state for the different operations to represent how patients might perceive their outcomes to be, or their quality of life to be different, depending on kind of how they've had the operation, how they perceive their quality of life after. So they varied that between 0.9 and 0.99 for abdominal colectomy, a total colectomy, and they kept segmental colectomy at 0.99, and IPAA, they varied that between 0.85 and 0.95. When we looked at a total colectomy, there was lower total colectomy utility states, resulting in a greater mean quality of life years offered by segmental colectomy, which makes sense because as we lower the utility state of total colectomy towards a 0.90, it makes sense that a segmental colectomy, if you offer that, would offer a better because they kept that at 0.99. However, when we look at the IPAA utility state, even at the lower ends of utility of 0.85, there is no significant quality of life difference between the mutations of either a segmental colectomy or total colectomy. This table, or these tables, to summarize kind of essentially what we've said in the previous slide. The main thing we want to draw or highlight was when we're looking at survival. So in table 2, there was no greater difference of 1 year. So if you look at the difference of segmental versus total colectomy, it doesn't reach more than 1 year, so never more than -1. And when we look at quality adjusted life years in table 3, again, similar things. Segmental colectomy didn't offer more than 1 year difference of quality of life adjusted life years, irrespective of the mutation. So these results tables, or the charts, essentially try and show the difference in overall survivals depending on the mutation that's present, assuming the diagnosis was made at age 25. Now, what we can see here, what we want to draw your eyes to, is the kind of green line that shows that the primary difference in survival between segmental versus total colectomy was at the years between 40 and 60 years for the MLH1 and the MSH2 mutation. So that's where it offered the greatest difference in years of survival, assuming they lived to these years. And then they kind of gradually moved back to the difference being 0 because this model was only run until the patients reached 100 years of age. And there was less of a difference in terms of survival when we look at the MSH6 mutations and segmental versus total colectomy. The results were pretty similar there. Again, this graph just highlights kind of what we've talked about so far. It highlights the difference in survival, so the straight line or the blocked lines, and how the difference in survival kind of decreased for all mutations as the age of diagnosis increased. So the greatest difference was seen the earlier the diagnosis was made in terms of survival. Then if we look at quality adjusted life year, and this is comparing segmental colectomy versus total colectomy. And then if we look at quality adjusted life years, so the dotted line above, very similar figures again that we've talked about. So as the age of diagnosis increases, then the difference in the quality adjusted life years comparing segmental and total colectomy decreases. So if we just briefly talk about the limitations of the study that we've just discussed, self-reported on the paper itself, they acknowledged there was a lack of PMS2 mutation-specific data, so they haven't reported that purely because the data wasn't there. They acknowledged that using a linear model may not be beneficial to assess metachronous cancer risk beyond 70 years of age because the data wasn't there either. And they haven't commented on whether there would be any difference in the benefit of the options given segmental versus total colectomy, depending on the patient's adherence to their colorectal screening, which you know is increased in Lynch syndrome patients. In terms of limitations that critiques that we've drawn from the study itself, these are just some of the ones that we've highlighted. So the impact of surgical morbidity is oversimplified. If we look back at the methods that they used, so they decreased a patient's quality of life, quality adjusted life year by 0.15 for any surgery that they had for that 1 year. We know that surgery is more complex than that, and we know that patients having multiple operations are at increased risk of greater morbidity, and they don't account for the increased morbidity that may occur as a result of a complication, even if mortality doesn't occur as well. They've got significant publication bias because all of their data, most of their data that they've used is come from previous literature, and therefore we know that kind of more positive data is more likely to be published, so that increases the risk of bias. We've talked about multiple assumptions that they've made in this paper. Just to draw on two key ones, they've assumed that the utility state of a segmental colectomy is going to be 0.99. There was no data, and they've acknowledged that, to be fair to them, that there was no data suggesting this utility state for a segmental colectomy. So they've just pulled this figure out of thin air. So that's a big assumption there. And they've also assumed, as Pratik correctly talked about, that the metachronous risk between the colon and the rectum would be 50-50, when it's very unlikely to be the case. And then briefly, just to finish off in the limitations, they've talked about how there's a kind of discounting related, discounting year on year of 0.02 utility states, which they have taken from previous literature, but obviously oversimplifies things as well. So to briefly conclude, the paper acknowledges that patients with different HNPCC mutations may benefit from different surgical strategies when taking into account the metachronous risk and their quality of life with the procedures that are being offered. In terms of what we generally think about the paper, some positives about it. It's quite a novel methodology. Both me and Pratik talked about how we hadn't seen many papers like this before. It took a bit of getting used to, but it was interesting to see the different type of research that's being undertaken. And it's definitely relevant to colorectal practice, and specifically Lynch patients. In terms of the drawbacks and limitations, obviously it's a simulated study subject to a variety of biases, which we briefly touched upon. The results are not generalizable, and there's doubtful validity because of the biases that we've talked about in general, which obviously decreases the amount that we can take away from the study itself.
As usual, a brief summary of what we discussed after the paper presentation. First of all, we pointed out how we feel a 50-50 distribution of metachronous occurrences between colon and rectum as part of this model seems to be slightly biased. We know from the literature that the vast majority of metachronous cancer seems to occur in the colon rather than the rectum. We also discussed the role of aspirin for chemoprevention of cancer in Lynch patients, which since the publication of the CAP study has been fairly common. We think that perhaps introducing the use of aspirin as part of the model since the publication of CAP2 study would have helped generate a more accurate prediction. We also talked about how these models are often biased by arbitrary choices made by the authors, particularly in terms of the choice of how many qualis a patient would lose following an operation. It is always difficult to guess, and sometimes it is indeed an oversimplification of the issue. Finally, we touched upon the fact that, the finding of the study certainly applied to people that have a diagnosis of Lynch. However, the vast majority of people that do suffer from Lynch syndrome are diagnosed after their primary resection, and the vast majority of them do not know that they have it before their cancer occurs. We'll flag up all these issues with the authors, and we'll wait for the answers.
So tonight we will carry on talking about statistical tests, and we are going to take a little step back because I felt perhaps tonight we will have a few new people joining that might have not seen the previous episodes, and I didn't want to kind of jump into something very complicated today. So we're going to have a quick look at some assumptions, particularly about the normal distribution, and we're going to dig a bit deeper into that, talking about skewness and kurtosis. Two arcane terms that we will aim to explain tonight. Obviously, the data is wrong, ignore it. Two disclaimers, as usual. I'm not a statistician or an expert in statistical software, but I practice it a lot, and I like to share my limited expertise with you guys. We talked about assumptions in the past 12 lectures. Particularly, we focused on normality and skedasticity, and I prompt you to go back to the videos that we got published on our website to look at that into more details. But tonight, we are going to look at normality in a bit more details. And as you can see here, we've already covered quite a lot of statistical tests, including some history notes about them from students T all the way to nonparametric ANOVA, a Kruskal-Wallis test. The plan for today is to take a step back, as I said, and move back on to normally distributed versus skewed data, and dig a bit deeper about the differences between the two. We're going to use Jamovi. If you scan the QR code, you'll go straight to the Jamovi website. It is a fantastic piece of statistical software. It's completely open and free for you to use. So, the normal distribution. This is what we're going to focus on today. You will most certainly have seen this wonderful bell curve shape, and what all this number means in the past. We'll go back to this later. We'll start by asking Maddie a very important question. What is an assumption?
So an assumption is a property of the data that you're looking at or handling that's taken as true.
Fabulous. Yes. Do you want to give me an example?
Yeah, so an example could be randomness. So assuming that the sample of the population that you're analysing is taken randomly from the whole.
Absolutely. That's a very common assumption that is often overlooked. Whenever you are looking at a sample of anything really that you include in a randomized controlled trial, for example, you assume that the patients you're including in that randomized controlled trial are a random selection of patients that have that particular disease. It is an assumption. It might not be a random selection. And often that is criticism that is moved towards a randomized controlled trial, because patients that are more interested in their healthcare, patients that are more tuned into their diseases, they will tend to seek participation in a randomized controlled trial, which to an extent is a form of selection bias. Anyway, most RCTs will have, and the calculations behind RCTs will use randomness as one of their assumptions. We talked about a few assumptions in the past, including randomness, but what is the assumption that we most commonly talk about?
Well, the one I've heard the most is normality.
Yeah, I think by now it must be imprinted in your brain, Maddie. If you're talking about normality, then we're talking about the normal distribution, which is what we just looked at. What is a normal distribution?
Well, if you go back to that slide, you can see it's a distribution where the mean, median, and the mode are the same, and then the data is equally distributed to the right and the left of them.
Yes, absolutely. And you can see how if you take the standard deviation and you go -1, +1, you'll have 68% of the data in between. -2, +2, 95% of the data, and then -3, +3, 99.7% of the data. And that's why vast majority of papers, when they present you data, they will present you a mean ±2 standard deviations. If that makes sense. Now, we have reviewed what a normal distribution is. So why is it important to know if your data is normally distributed or not?
Well, as we've been learning, Gio, because this determines what type of statistical tests you can run on it. So parametric tests for normally distributed data, and then non-parametric tests for non-normally distributed data. So you need it to run the rest of your stats.
Absolutely. And if you go back to the plan, you will quite obviously notice a split. Continuous data, normally distributed, skewed, aka non-normally distributed. And the tests that you run here are very different. So it is important to know, you're absolutely right. So then, difficult question. How do we check for normality?
Well, as we've said previously, you can do it in two ways. You can either do it visually by plotting your data frequency on a histogram, as you have shown here, or you can use the Shapiro-Wilks test, which tests the null hypothesis that a sample belongs to a normally distributed population. That's to say that if the result is has a p-value of less than 0.05, it means the data is not normally distributed. And you can do that on Jamovi.
Yes, you can, and we'll do it again probably later. Now, is there another way to say what you just said? Can you just rephrase that p less than 0.05?
Yeah, so that's the chance of the data being normally, put my teeth in. That's the chance of the data being normally distributed, less than 5%, as that's what a p-value of less than 0.05 means.
Yeah, so that's very important, generally speaking, to remember. You might get asked at an exam or an academic interview, what does p-value mean? P-value is simply a numerical representation of the chance of the results being random and not being due to a true difference. And it is set as 0.05 or 5%. So 5% chance of the data looking like this by chance and not because it is not normally distributed, if that makes sense.
Mm-hmm.
Any questions so far about that? Probably not. Right. So when we talk about the normal distribution, like we've done before, we normally mention sort of normality, mean, mode, median, and things like that. Now, there are a couple of characteristics of distributions that are important to remember, and you can see a couple of examples here. The one at the top is called skewness. That is to say how deformed the distribution is to the left or to the right in comparison to the normal distribution that you can see sort of in the middle. The one at the bottom is called kurtosis. And kurtosis is a measure of thickness of the distribution. And we'll go into some more details about skewness first. Now, skewness can be measured. And there's a number of ways to measure this. The simplest, sort of oldest published measure of skewness is Carl-Pearson's index, which is reported there. We use, and most statistical software use, a slightly more complex and advanced measure of skewness. Now, it is important to remember one thing, that the skewed distribution is not normal, because obviously it's not a traditional bell-shaped distribution. However, like most things in life, normality does not live in a 0 or 1 state, but it lives in a spectrum. So there is a degree of skewness that it is accepted as being near normal. And normally, between -2 and +2, it is accepted as somewhere where you can run a parametric test anyway, even if the data is slightly skewed. Because at the end of the day, the vast majority of the data that you'll be analyzing is a sample. And it can be as large as you like, but it might not be large enough to be exactly normal. So it is an acceptable margin. It is not universally recognized. Some texts talk about -3 and +3. Some texts talk about -1, +1. So there isn't an absolute consensus. But -2 to +2 is what I most commonly found as being considered acceptable skewness to still consider your data reasonably normal. Positive skewness means skewness to the right. Negative skewness means skewness to the left, which is the example you can see on the other side. Positive skewness means that your mean is bigger than your median, because outliers to the right side of the curve affect your mean much more than they do the median. And that's why we use median when the data is not normally distributed and not mean, because the median is more reliable, if that makes sense. That's it for skewness. I'm not going to bore you anymore. We'll move on to kurtosis. Now, as we said, kurtosis is a measure of peaks. But what do peaks represent? Well, ultimately, the peakness of a distribution is an indirect measure, well, it's a very direct measure actually, of how many outliers are present in said distribution. And if the normal distribution is the one in the middle, you can see a distribution with negative kurtosis that's got a much flatter look, less central values, and more outliers. And the positive kurtosis, where the distribution is much more narrow, it's got many more centered values and less spread out outliers. If you want to be technical, a positive kurtosis distribution is called leptokurtic, and the negative kurtosis one is called platykurtic, like a plateau because it's flat. A normal distribution has got a kurtosis of its own, which is 3. So anything above 3 is called leptokurtic, anything below 3 is called platykurtic. Most commonly, statistical softwares will report one of the two, either actual kurtosis or excess kurtosis. Excess kurtosis is measured -3. That is to say, like if the normal distribution kurtosis was 0, if that makes sense. At the end of the day, it makes relatively little difference. Holisticity is important to look at kurtosis, and extreme values of kurtosis will prompt you to think, oh, actually, I shouldn't use a parametric test. I could not find an absolute cutoff where actually you shouldn't use a parametric test in this situation. So it is important to look at it, but I couldn't find a number to tell you, actually, this is the value where you stop using a parametric test. Right. I'm not going to give you any more information tonight. I think I have probably tired you enough given this time of the day. But I am going to show you how to have a look at all this in Jamovi. I don't know how many of you have been on the previous sessions, so I apologize if some of you have been seeing this before. And please ask me any questions if you like. So we open our Jamovi. This is a data set of papers that have been published on various journals as well as tweeted. And I've got some data about how popular they've been on the Twitter network when it was called Twitter. We go on this exploration and descriptives here. Let's say that we want to check, for example, time cited. So how many times a paper has been cited across all platforms. We'll tick that there as a variable, and we can see that Jamovi immediately gives you a little bit of information. So this is telling us that the mean is much higher than the median. It already suggests that the distribution is skewed. Now, Maddie, can I ask you an additional question?
You can try.
Perfect. The mean is much higher than the median. So the distribution, where do you think is skewed? To the right or to the left?
Would it be to the right?
Yes, correct. Absolutely, to the right. And if we go on plots and ask for a histogram, you see that it's very skewed to the right. See how many outliers are over there?
Mm.
It's a massive amount. And you can guess that just by looking at mean and median, that this data is not normally distributed. But we can do better than that. We can ask Jamovi to calculate skewness and calculate kurtosis. And the numbers will relatively impress you. Kurtosis is 41, skewness is only 5.52. So this would suggest again that the data is not normally distributed. If you then want to run the now famous Sheffield-Wilk test, you can do that here, which will again suggest that the data is not normally distributed because our p-value is less than 0.001, which means a less than 1% chance of these data being looking like this by chance and not because it's not normally distributed, if that makes sense. Jamovi does way more for you. You can get mode, you can get percentiles, quartiles, you can get box plots, which again will show you how abnormally distributed the data is. If you're interested about box plots, look at our previous video from a month ago when it is available for you to watch, because I don't think I've edited it already. Give you a more extreme example. Jamovi is very smart. All I need to do is just do that, and he will redo the same for everything, including giving me retweets just here. So you can see how kurtosis for retweets is massive, and skewness is also very high. And if you look at the way the histogram looks like, it is even more to the right than time cited. And so does the box plot. I think that's all I wanted to show you for tonight. So I will not bore you any further. I'm going to stop sharing. And I am going to stop recording as well.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.